everyone, and welcome to the Farley Center panel discussion on healthcare innovation. We are very happy to have you here. I'm Hayes Ferguson, director of the Farley Center, and I'm thrilled to introduce our moderator and panelists. All leaders in their fields. They will discuss how the latest advances in healthcare have taken off during and because of the pandemic. They also will talk about how the very process of healthcare innovation is being rejuvenated and reinvented right now. Our moderator is Vijay Vaitheeswaran, Farley's Distinguished Visiting Fellow. Vijay is the US business editor of The Economist, where he's used his background as an MIT-trained engineer to write on a wide range of topics over the past 3 decades. He chairs the Economist Innovation Summit, a series of global conferences on innovation. And in his role at the Farley Center, Vijay contributes to courses through collaboration with students and faculty and through participation in special events like this one. Welcome, Vijay. We're thrilled also to welcome our panelists. We have Vivian Lee, a physician and healthcare executive and the author of a book called The Long Fix, Solving America's Healthcare Crisis. She is president of health platforms at Verily Life Sciences and is a senior lecturer at Harvard Medical School. Welcome, Vivian.
Thank you, great to be with you.
Next up is Milton Morris, the president and CEO at the medical device company NeuSpera. He is an inventor and an author on many peer-reviewed publications and book chapters. He's an alumnus of Northwestern, where he received his MBA and Bachelor of Science in Electrical Engineering. He also is a member of the McCormick Advisory Council and Northwestern's Board of Trustees. Welcome, Milton.
Thank you, Hayes. Good to be here.
Last but not least, we have John Rogers, the Lewis Simpson and Kimberly Querrey Professor of Material Science and Engineering, Biomedical Engineering, and Neurological Surgery at Northwestern. John is a pioneer in the bioelectronics field and has invented dozens of medical devices that have the power to create the sensation of touch in virtual reality, wirelessly monitor babies in the NICU, and much, much more. Welcome, John.
Hello, everyone. Hi.
Before I turn the mic over to Vijay, I want to let the audience know that we'll be answering questions at the end of our discussion today around 2:40 p.m. Central. So feel free to post your questions in the Q&A chat section of your screen. It's my pleasure now to turn things over to Vijay.
Thank you, Hayes. It's such a pleasure to be with you today and to talk about one of my favorite topics, not just about how innovation is changing, but how innovation is taking on one of the most challenging areas of human endeavor, one of the areas in which it's most difficult to bring about change. In the healthcare system in the United States is about 18% of GDP, roughly a fifth of our economic activity, but it is a colossus. It's very hard to innovate rapidly or do what Silicon Valley startups love to talk about, disruptive innovation, move fast and break things. Well, it's pretty hard to move fast and break things when people's lives are at stake. So you need to think about innovation in a different way. You need to think about value creation, payments in a different way. So it's a different endeavor than, let's say, a theoretical blank sheet of paper or free market. It poses additional challenges, but also, is it possible, we want to explore today, that there are also new opportunities being created as well. We know the human need is great. The pandemic has made that evident. The areas where we can do better on public health, the areas where we can do better on technology, be that tracking, tracing, or some of the advanced biometrics, sensors, and advanced engineering we'll hear about in a moment from John. But what can we do better in terms of understanding how innovation itself is being unleashed in this area? That's what we want to dig into. It has been observed that in small crises, power gets concentrated at the center of organizations. But in great crises, it's often decentralized. It becomes too much for headquarters or senior leaders to handle, and it makes more sense to have power more dispersed and have decentralized solutions that are more responsive to local crises and local conditions. So we want to explore that a bit with our gurus and our doers who are with us today. Vivian, let me turn to you first. You've written a wonderful book, The Long Fix, which I recommend to everyone on this call. But take us to the pandemic and where you are sitting, leading some of the healthcare efforts at one of the world's biggest, most innovative companies within Alphabet, within Google's efforts in healthcare. Can you tell us how do you see the pandemic affecting innovation in the spaces we're talking about? Health technology, healthcare.
Oh, well, thanks, Vijay, and thanks for everybody for inviting me to join this panel. Actually, I really like the way that you framed it in terms of the innovation that has been driven by this pandemic, and particularly the fact that it is a decentralized effort. The company that where I lead health platforms, Verily, as you mentioned, is a part of the Alphabet family. We were originally Google Life Sciences, and we were part of Google X. And then when Google became Alphabet, we were spun out as part of that, and purpose-built for life sciences and healthcare. Just a little background for those of you who may not be familiar with the company. And so a couple of things. One is we really were very focused in the pandemic, as everybody was, on what we could do to support the nation's response. In fact, we were called upon by the governor's office in California and then by the White House to help very early on, particularly when we recognized that there just was not enough testing available. And so almost overnight, we stood up first a community testing program, leveraging our clinical trials. We have a clinical research platform, and we just really morphed it overnight into a COVID-19 testing program, and then expanded that to employers, to universities, to people who were trying to think, how can we bring people back to campus safely? And so really, in response to COVID, had to reinvent at least that part of our company. But then we're able to leverage existing technologies like a temperature sensor that we actually had been building for cancer patients. Now all of a sudden became of great interest to people who wanted to monitor people for unsuspected COVID infections, for example, or leveraging our data scientists to build epidemiologic models around how can we predict where COVID is taking off. How often should people get tested for COVID who are asymptomatic? That was a question that people were asking us a lot. So we could use our data science in that way. So we saw a lot of response just specifically to COVID. And then separately, we saw a lot of need for our digital health solutions, telehealth, remote monitoring of patients with chronic diseases. And those parts of the business also really grew and had to innovate very rapidly in response.
That's great. That's a great way to set this up, looking at things in response to the immediate crisis, but also how trends that were already in motion may have been accelerated by, again, the experience of the pandemic and the potential for innovation. We've seen this, of course, with things like the Netflix effect, as it's been called in entertainment, or the Amazon effect in digital commerce, that things were already taking off, but then there was a massive accelerant during the year of the pandemic. And we may see things that outlast the pandemic, as well as what I'm hearing from you, Vivian. But before we get to those longer term trends, I just want to spend a moment on technologies as they relate to the pandemic. I think it's fair to say, we're going to talk about some of the incredible advances that are coming, and John's been working on some of them. But I think it's fair to say the US has not been the leader in the world on the use of technology during the pandemic. We know that countries like South Korea, Taiwan, to some degree Singapore, have done better with certain elements of tracking and tracing or using of smartphones. Can you give us a sense, Vivian, again, bearing in mind that there are a lot of great things that we have done, but what is the reason we have not done better? What is it to do with the nature of our regulatory system and HIPAA rules, or is it to do with something else, market factors? Can you give us just a glimpse, since you're at the cutting edge? What have you learned from your own efforts with the state of California, and what could we do better?
Well, I think many people have weighed in on what we could have done better, or even could continue to be doing better in terms of our nation's response to
Well, give us your biggest thought on
COVID-19.
that area. What do you think is reasonable to say? It's always easy to criticize after the fact, but you're literally on the front line. So give us your insight.
It is. Well, maybe I'll just take I'll take maybe one piece of it, and I won't talk about what I think is probably the biggest problem, which is the lack of public health infrastructure in the country. to really coordinate both local, state, and federal response to public health crises. I won't talk about that because that's not really my area of expertise. But what I will say is I think that what it has revealed from a health system perspective, because that is probably an area that I do know a little bit more about, is just how much our current healthcare system, in a kind of a fee-for-service model of care, very focused on tertiary, quaternary care, high-end, expensive, revenue-generating care, as opposed to public health prevention, primary care, how vulnerable that has made our country. And I think we've seen that during the COVID pandemic, while our ICUs were filled, we didn't have good measurement systems for how many ventilators we had and beds we had. At the same time, we had so many empty clinics and all operating rooms, which then really depleted the reserves of so many of our health systems. And so just when we probably needed more people than ever, we were furloughing doctors and nurses as a result of our what I think is a business model of healthcare that's really not sustainable. And what we saw during the pandemic was many of the more cost-effective ways of caring for people, like telehealth, some of the remote monitoring for digital technologies that have been really on the back burner because the payers have been afraid that they might be overutilized. As a result, they haven't been paying for them until the COVID pandemic. We've seen how critical and how vital they can be to a functioning healthcare system and to improving access to care for more people. So I think it's really a very harsh light. It's cast a very harsh light on our existing healthcare system. It's really shown how systems that are more value-based, systems that have already been, for example, moved to models of getting paid for better health outcomes, like the Medicare Advantage programs, like the military health system and the VA, frankly, who are on fixed budgets. They've been able through COVID to actually invest the incoming steady source of revenue that they have on caring for their populations rather than having to furlough doctors and nurses just when they're most needed. So we can see that, at least I think one of the conclusions from COVID is that some of the more value-based models of healthcare not only are better for the business, they're going to be more cost-effective, but they're also going to make our system more resilient.
That's great. So 2 points. One, just as an intellectual observation, we need better public health infrastructure, but specifically about a health system, the fact that we have a system with incentives that have been called by economists perverse incentives, that is, we pay for piecework or transactions rather than paying for outcomes or value. That is a real problem, a real challenge in our healthcare system. And so that's a good starting point to sort of set the frame. Milton, let me come to you next. You're an entrepreneur. You have to not only try, but you've succeeded in this fractured and complicated ecosystem. Give us some insights about how you navigate the complexity of healthcare, given that it's not a traditional market where you come up with a great gadget, you address unmet needs or find a unique selling proposition, and all our MBAs who are on this call today would know, you're supposed to get rewards in the marketplace, right? VC will come flocking and you'll have the next great app or whatever it is. We'll all go on Clubhouse next. So what's different in your experience with healthcare?
Well, since the pandemic has begun, well, I should say, first of all, thank you for having me and thank you for the question. And, the first thing is during a pandemic for a company like ours, which is a clinical stage company, my company is NeuSpera Medical. We make ultra miniaturized implantable devices that are powered wirelessly. They are leadless in their form factor and are implanted almost through a straw. So think of something that is the least invasive implant that you can imagine. We have bidirectional communication, which gives us the opportunity to pull biometrics out of the device. And because wireless connectivity is almost ubiquitous, we have the opportunity to pull that information and provide it in a packaged format to healthcare providers as well as to the company itself. So lots of ability for digital health in my particular company, and we have a lot of interest from an investor base in the cultivation of that digital health and making that more of a reality going forward. you asked a question around the pandemic and how that's changed our ability to be successful. So we are a startup company. We are in clinical stages, I mentioned before. During the pandemic, as you would remember, many of the operating rooms were being conscripted to handle patients who are struggling with COVID. They needed more beds, they needed more hospital space. What we saw in the industry is a slowing down, almost a halt of clinical trials. We could not enroll patients, we could not implant patients for a period of time. It lasted probably for us about 2 months, realizing that the only path forward for us really were in ambulatory surgery centers, physician-owned ambulatory surgery centers, where physicians were actually able to make progress. And so from a resiliency point of view, the only way for us to move forward was to emphasize this site of care versus a school like Northwestern or any other academic institution where hospitals are actually driven by different means. So we've had to morph in a number of different ways. We've also had to move around through travel restrictions that are different from state to state. We have an international clinical trial. Those policies are different from country to country as well. So having the ability to move forward in the context of all that means rapid testing, which is an innovation in and of itself. It continues to get better. Over-the-counter testing became very important for us, and the ability to really manage your lifestyle and your work in the context of a bubble and quarantine, and still move studies forward. We were able to do it. Here we are at 34 patients implanted, closing out our phase 1 of our clinical trial. We're happy about that, but did take quite a lot of adjustment.
So a tale of agility on your part and that of your team, a tale of, again, dealing with adversity. And it might be surprising to those folks listening who are not in the healthcare field. You might think that a global health pandemic, the biggest health crisis in many decades, might be somehow good for the healthcare system financially. But of course, it's been a tragedy, devastating for many hospitals, because the profit centers of various forms of care, elective care, optional care, quote unquote optional, right? People are even delaying cancer screenings and such, which is not necessarily a good thing to do for health, but it has dramatically hit the finances. The American Hospital Association estimates that hospitals have lost billions upon billions of dollars a year in revenues that they would have had otherwise from all of those other ancillary services that are core to their profitability, that cross-subsidize things like emergency care and so on. So it's been a hard time for providers, but also for startups. But we do see the importance of healthcare, of health innovation rising among the ranks with venture capital funding, for example, which I track. And I see that there is more interest from some of the bigger companies that are looking at the value proposition coming out of this period, short-term period, we hope, of the most acute phase of the pandemic. How do we reorganize our health ecosystem to encourage innovation, to reward entrepreneurs like yourselves or those that work on long-term projects like John? And so maybe I'll turn to John. John, can you give us your perspective? I know you think you spent your career thinking about advanced engineering and the confluence of industries, and your multiple titles that you hold at Northwestern gives an idea of your interdisciplinary thinking, your integrated approach to design, to looking at coming up with solutions. Can you give us a sense of how you've experienced this pandemic from the innovator's point of view?
Yeah, sure. I mean, thanks for the question. It's a real pleasure to be part of this panel. I've enjoyed hearing, thoughts and perspectives of Milton and Vivian and so on. I'll share some of mine from the lens of an academic, engineer. So I run a large academic group here at Northwestern, and we've been thinking pretty deeply about what would be possible if we could create forms of electronics that are radically different than those that serve as the basis for consumer electronic gadgetry, say your smartphone or your laptop, into platforms that are intrinsically biocompatible, not only from the standpoint of the materials, but also the geometries and the form factor and the mechanics specifically, and really exploring different kinds of ideas in that general space with an eye toward unmet clinical needs, I think specifically in the context of the most vulnerable patient population. So with a focus on maternal, fetal, neonatal, pediatric health on one end of that age spectrum, and then Parkinson's patients, patients suffering from Alzheimer's, dementia, and stroke survivors kind of at the other end of that extreme. And so we've been developing all kinds of different sensors and biointegrated electronic devices that interface with different organ systems of the body, vital organs. So the brain, the heart, the bladder, the spinal cord, the peripheral nervous system, and the skin has been a main area of focus as well. And thinking about what the next generation of wearable devices is going to look like. What comes after the Apple Watch or the Samsung Gear or the Fitbit. What would we be able to do from an engineering standpoint to sort of morph those kinds of platforms, which are really good at counting steps, but really bad at capturing ICU grade, clinically meaningful, high quality data streams. Like, how do you bridge that divide, And so we've developed a portfolio of devices that really go on the skin like thin Band-Aids, or in some cases almost like kids' temporary tattoos, so they can really intimately come into physical contact with the skin in a way that's more or less physically imperceptible. So you sort of put it on and you forget that it's there. And with that skin interface, you can do things that are qualitatively beyond what's possible with a rigid block of electronics rattling around on your wrist. One thing, you can locate those devices on relevant parts of the anatomy, depending on the use case, and you can exploit that skin interface as a window for making sort of ICU grade, clinical grade measurements of underlying physiological processes. So,
John, you've got us so excited about the prospect of the future. Tell us a specific example. What's a device I can get my grubby paws on right now?
Here's a specific example right here.
Okay, what do you got there? What is that?
Rewind, one year ago, we were doing a number of different things. Like I mentioned, maternal, fetal, neonatal health is very interesting to us, not only in sort of the developed world, but also lower and middle income countries as well. So about a year ago, I was in Zambia in health clinics deploying devices of this type onto neonates, premature babies, monitoring vital signs, and so on. We're pretty well plugged into the medical community here in Chicago. This particular device we developed in a close collaboration with the Shirley Ryan Ability Lab, and it's designed to measure swallowing events and speech activity associated with stroke survivors who are suffering from dysphagia or aphasia. And with this device, you can sort of track speech patterns, you can track swallowing events, frequency of swallows, when the swallowing has happened relative to the respiratory cycle. And it turns out that information is very important in sort of personalizing a rehabilitation protocol to an individual. The alignment of this device, though, with COVID-19 and the whole pandemic was sort of coincidental in a sense. If you think about COVID-19, it's a respiratory disease. If you want to monitor respiratory activity, you don't want to be on the wrist or the finger. You want to be on the chest wall or on the suprasternal notch where this device is located. So we got a lot of inquiries starting around middle of March of last year from the medical community who's aware of this device, asking us if we could customize it for the main symptoms of COVID, which is cough, fever, and shortness of breath. And so we were able to get, essential personnel designation very early on, adapted this device for monitoring of early signs of symptoms in frontline healthcare workers and monitoring the progression of the disease in patients who had contracted COVID, both in the hospital and after they were released into the home. So you can sort of monitor how they're responding to novel therapeutics, how they're progressing. And if there's a dangerous situation that develops when they're in the home, you see that through the data streams. Immediately you pull them back into the clinic. So we've been mounted now or deployed on about 500 patients in the Chicago land area over the last 20-30 weeks or so, with tremendous amounts of data. So there's a really interesting confluence between new sort of soft body integrated electronics and data science, big data and machine learning. And so those pieces are coming together in a really interesting way. And I guess our feeling is that these digital data streams can complement the kind of molecular-based tests that are being performed, in a way that doesn't involve consumables, and so you have an infinite amount of information and you can, harvest insights from that data in a way that sort of can pair nicely with traditional, molecular-based tests.
Let's stop there for a moment, because there's so much interesting stuff you've said. the data streams and data deluge, how to handle that and the role of AI analytics. We're going to get to that in a moment. I want to turn to Vivian because I know her company has investments, for example, with in diabetes care that I want to talk to her about a little bit, her perspective on medical devices and the digital side of this in just a moment. But just to reflect on your observations, you've been able to get this device into patients in the moment and looks like you're having some promising results. What is the pathway to getting this widespread? How do we get it to 1 million or 100 million people? Very briefly, and then I want to come to Vivian on her thoughts.
Yeah, so just a couple of quick things. Because we were already deployed on 100 or so stroke survivors, we already had all the IRB approvals for human subject studies in place that would allow us to go very quickly onto healthcare workers and COVID-19 patients. So we could almost immediately adapt the device, get it onto patients, and that was very powerful. We had to establish sort of a data infrastructure, however. So we established a HIPAA compliant cloud service through AWS, and then implemented algorithms in the cloud for analyzing the data and producing sort of a graphical dashboard by which the physicians could quickly monitor the status of their patients and the status of the nurses and the rehab specialists that are working under their supervision. So those initial deployments were made possible by the fact that we have this special institute here at Northwestern, and we actually have manufacturing equipment in our lab. And so we could do low volume manufacturing even when all of our normal outsourced manufacturing partners were shut down because of the pandemic. So we can do tens of devices per week, but we've designed the manufacturing flow to align very nicely with established capabilities that are serving the consumer electronics gadgetry industry. So there's inherent scalability there. We have a large multi-million-dollar grant with the DoD and with BARDA to scale to several thousands of devices, and we're right in the middle of that program now. But in principle, you could do millions of units. It's really
so there's no red flags that you want to put up. It sounds like it's work in progress.
No, it's straightforward.
Okay, Vivian, let's turn to you. You've got experience at your company, certainly with the innovative medical devices. What's your perspective on this? And again, I think we talked about a novel approach to continuous glucose monitoring and sort of a holistic approach to thinking about diabetes treatment. Tell us your experience that you have at Verily in this.
Yeah, well, let me say that I think what John is describing is exactly what we need more of in the market. We, in the course of, actually, I've just been working on the epilogue for my book because as you know, having written so many books yourself, that in the paperback version, they actually wanted an epilogue. So I've been actually going around and talking with many of these different health systems about how they're managing their patients with COVID at home. And the key is they need more remote monitoring technologies. And right now it's a bunch of different pieces, right? They have an oximeter and they have the temperature and they, all these different pieces, and you've got to manage all that hardware. So, so kudos, John, for the work that you're doing. I think that's fantastic. And I think the challenge in this space right now is we see a huge opportunity, and what we really need are these technologies that can be available at low cost, where the data are integrated in a way that it's accessible, of course, to the individual as well as to the health systems that are trying to use a word that I really love, co-produce health, so that the provider and the patient can work together and co-produce that health. So the data needs to, again, be available to both in that accessible way. So as you mentioned, we have thought a lot about these various technologies in terms of patients who have chronic diseases. And I've been working with Dexcom for years to help design and build the continuous glucose monitors. Mm-hmm. Sorry about that. And so that has been a really transformative experience because, as you know, people who have type 2 diabetes often have to prick their finger multiple times a day to draw the blood and to test their blood sugars. And even then, it's just one test, one number in one point of time, just not very much data, right? So for the first time, you actually, when you have a continuous glucose monitor, which is about the size of a key fob on your arm or on your abdomen, now you can measure your blood sugars 24/7. And that signal is transmitted to your app, say on your phone. You can take pictures of your meals and snacks. You can track your sleep, your exercise. And so for the first time, people can make an association between what's happening with their blood sugars and their activities, especially what they're eating. And then if you layer on some AI on top of that, you can gain some insights that, maybe Vijay, for you, soy milk is better in your coffee. For me, maybe skim milk is better, or, maybe the eggs are better than the oatmeal and so on. So it's just really helpful, really, really engaging technologies. And at this point in time with COVID, when people are afraid to go into the clinic, they're afraid to be seen, this ability to do this at home on their own phone in a very personalized way. You see your own biology and physiology playing out. I think it just signals that this is really the direction forward, I think, for so much of healthcare.
Great. So we're really seeing a couple of themes emerge. One that's come up a couple of times, that is the move towards remote monitoring. Now, given lockdowns and the nature of COVID, it makes perfect sense. But there are some problems that would have in any case have been better if the technology and systems around it had been in place to monitor people in their home, where people are more comfortable. Even if necessary, nursing or other staff can come to your house occasionally to give a treatment, but the continuous care is now possible because we have reliable communications, the security needed to keep the data safe, connect with your provider, and to Vivian's last point about how it connects with skim milk or soy milk, changing behavior, helping empower individuals so that we are able to take greater charge of our own healthcare. That's not typically how healthcare has been. It has been much more paternalistic historically over time. The doctor, of course, was all-knowing and all-powerful and often didn't tell you in the old days what you needed to know. They just told you what to do. Milton, I want to turn to you because you're coming at this as an entrepreneur. And you're looking at markets, presumably some of them are B2C markets, consumer markets, where people might pay out of pocket for devices or for treatments. But you have obviously the biggest addressable market, probably, I imagine, has to do with payers and insurers and the whole tangle of how you get your product regulated and approved so that you're within that ecosystem of providers. Give us a flavor of where does the individual fit in? We don't like to use the word consumer when it comes to health because people think it's tawdry. Oh, you're not just buying soap or shampoo, it's our health. Fair enough. The individual patient, when you think about the individual, where does that fit in your business model or your thinking?
Yeah, that's great. Outcomes do matter for us, and we do deal with patients who are struggling through chronic and debilitating conditions. From a health economics perspective, it's the copay, right? And the pull through as a consequence of copay. The larger the copayment for a particular technology, the harder it is to move that technology into the indicated population. It's just like an elasticity curve in any other market. So you're absolutely right, heavily regulated industry. We have to work with Center for Medicare and Medicaid Services for reimbursement, American Medical Association as well to get our CPT codes together for each of our procedures. And we've got to help physicians and practices remain profitable or to get to profitability through the proper price point for the products that we provide. If we can get all the pricing right, if we can get all of the reimbursement in place, then the FDA, if we can get our device through the FDA and approved, then there's the opportunity to actually extend and improve lives. And that's where patients ultimately get to benefit from our technology. But if our pricing isn't right, if the copays are too high, it can be all for naught. And we see that in certain areas of particularly implantable medical device technologies, where the price points can be awfully high. And even with high efficacy and high class 1 evidence, randomized controlled blinded trials that are all published in peer-reviewed journals, you can still see a very sluggish movement of patients to that technology. Our company is working toward cost-effective solutions, not cheap solutions, but cost-effective solutions that are priced at a point that allows for far more utilization of our technology. So one other point I want to make on remote patient follow-up. So our system is a wearable system. We power our implants externally through what we think are ubiquitous wearable systems, which is to say patients are not revealing their condition by wearing our system. Those systems rely on compliance. So therapy has to be efficacious, but the system has to blend in with the patient's use and their mental aptitude and capability. Otherwise, we're not going to be delivering the therapy, and we're not going to be delivering the outcomes that our therapy begs. So remote patient monitoring isn't just monitoring. For us, it's going to be remote patient care that patients are right at the center of through their compliance and using our wearable systems. So really important point to make there. And pricing is a big deal after all the regulatory pieces, and compliance to wearing the systems are going to be important, as you'll see far more wearables coming to the marketplace over time.
Milton, what is your experience of FDA and other regulatory approvals? I understand that there has been a fast track channel that the FDA has opened up for medical devices. I hear generally positive things from industry about this, but what's your experience as an entrepreneur? And I might ask Vivian for a quick comment, because I think your firm is involved in some of the advisory work to the FDA on this, but Milton first.
So yeah, absolutely. So we're on our way. This is an initiative that started probably a couple of presidential, a couple presidents ago. In any event, so there's a status called breakthrough status that you can apply for now as a company. That breakthrough status gives you some focus at the FDA for a more efficient review. You can apply for expedited review as well. That also gives you a more efficient review process. And with the breakthrough status, you actually can get a status that allows for dedicated reimbursement or assured reimbursement for about the first 4 years, I think, post approval from the FDA of your technology. Now, this first 4 years is a critical time period. Post FDA approval, many companies that are innovating on the technology side with the newest, most interesting technologies and therapies often don't have the coding to get their device paid for, and so virtually the technology is inaccessible to patients and providers until that robust reimbursement in all sites of care is offered. So a lot of companies fall by the wayside.
CMS, am I right, Milton?
Medicare, CMS, you've got to work with them, and that usually happens, or those approvals usually happen after the FDA approval. So breakthrough status allows for reimbursement to occur even before that coding is put in place by those regulatory agencies, allowing for access of this technology to patients that need it.
Okay, well, that sounds like a positive sort of statement or outlook for breakthrough technologies. Vivian, what's your experience?
Well, we've definitely seen, for example, with the COVID work, just how I just have to hand it to our colleagues over in the FDA. They have been really working very hard to try to be responsive, not only in terms of the COVID technology, but then, as Milton just alluded to, all of the other advances that we need to see happen, especially as our health system has been so disrupted. So we've been working very closely with our own leaders. We are very fortunate to have Rob Califf on our team. He was the FDA commissioner under President Obama, and he's been very helpful in guiding us through, for example, the approvals that we've been seeking around COVID-19 testing, just to make it available to more people. One of the advances that people might be interested in is the ability to do pooled testing. So I think you'll all remember that in the summer and even in the fall, there was a real shortage of reagents. And so just being able to pool samples so that you could do the same number of tests with fewer reagents was actually very critical for our own lab to be able to provide that CLIA testing. To Milton's point, I think he's raised this really important challenge that we have of reimbursement for new technologies. And I don't know if you were going to take us there, Vijay, anyway, but I think that's
Show me the money, Vivian.
Yeah, it's, as somebody who was being asked to pay for these technologies, I think that it is incumbent on us in the innovation space to be able to produce as much evidence as we can about the cost effectiveness of our products. And these trials have been hard to recruit in this year during COVID, but it is really, of course, really, really important. And at the same time, I think also that I'm actually, as you and I have discussed, Vijay, before, very interested in disruptions in the payment model that can be led by digital technologies. I think that rather than recapitulate the fee-for-service model of care, if we can truly show that we are driving more value in healthcare, that we're really making better outcomes and hopefully lowering the cost of care with our advances, then maybe that's how we ought to get paid. So, for example,
you're actually
with
leading by
Onduo,
example on this. I've advocated for a long time. I used to be our healthcare editor at The Economist before my current job, and among the things that I argued for was a shift in the incentive system within the U.S. healthcare system, which I think is one of the great reasons that this world-class health system with such innovation capacity doesn't deliver the best healthcare for all Americans. I think we can all agree we can do better, in part because of this misalignment of incentives. And among the things that make sense increasingly to people is a shift towards value-based care, integrated care. And you highlighted a couple of examples in your earlier comments. Now, I think you're leading by example in terms of business models and getting reimbursed for value. Can you just give us a quick example before we move to question and answer? And I want to encourage our participants to ask questions through the Q&A function, but please give us an example of what you're working on.
Sure. So with Onduo, which is our chronic disease management platform for people with diabetes, hypertension, mental well-being, and so on, in that program, traditionally we went to the market with a more of what I would call a fee-for-service model, per member per month kind of payment. So every employee that signs up for this and sort of clicks and uses the apps, that's how we would get paid per member per month or per employee per month. But starting last year, we actually said, well, if we're really committed to this idea of moving to value, let's put our money where our mouth is, and let's say, well, pay us for actually producing better outcomes. It's sort of like a money back guarantee. If we're able to improve blood sugar control in your employees who have diabetes, or reduce blood pressure in people who have high blood pressure or hypertension, then we get paid. And if we don't do that, then we don't get paid. And so we've been offering that in the market. Not all of the insurers or employers are able to work in that model because they're sort of set up to pay in the other model. But to the degree that they are, I think this is a good direction. It's certainly a direction that I hope that the digital revolution will, not only disrupt care, but also disrupt the way in which we're paying for care.
That's a great example. I hope we see more of that. And we saw it does work. We've seen the UK led the world with some of its innovations in payment for value, with even for medical drugs, for pharmaceuticals. The regulatory agents there that looked at this issue, they will reimburse at different rates depending on if a new drug actually works as promised, and not if it doesn't work as promised. And so that allows for larger payouts for innovative drugs than might have been otherwise. Europe is known to be pretty stingy about these things. But if you actually deliver the value that you promise, you can anticipate that you'll do better. But if you don't, then the taxpayer doesn't get stuck with that. And that's done through after launch testing, phase 4 clinical trials, as it were, or continuous monitoring, which often involves digital technologies as well. So we see how things come together. I see we have some questions lined up, for which I thank our audience. John, the first one is for you, and it touches on a really big topic, actually. And that is, what are your thoughts on the invasiveness and privacy concerns with a lot of the wearables coming out? The questioner points to Amazon Halo, but it's really a broader question about how do you think about privacy and how intrusive or invasive these might be? Where do the pros and cons come out in your mind?
Yeah, I think that's a good question, and it sort of touches upon some comments that Milton had around patient compliance, right? If they're not convinced that the data security is in place, it's unlikely that they'll comply with the use of the device. So there are a lot of aspects to compliance. That's certainly one of them. Yeah, I think that the devices also essentially have to be burden-free, like not even low burden. It has to be zero burden. For the devices we deployed on COVID-19 patients, for example, the devices have to operate in a completely automated way. You can't expect the patients to navigate through a menu and an app and file names and stuff like that. So security is important. Like I mentioned, we are using a HIPAA-compliant cloud. The BLE data, the wireless data is fully encrypted, and it's only transmitted over a relatively short range. The devices, at least the one that's mounted on the suprasternal notch that we're using for COVID-19, it has embedded memory. So it's not streaming data continuously. So the data is really not available until the actual download process happens. And that occurs over a fairly short range to a paired iPad, and then straight from the iPad up to the cloud. So I think security issues are going to be important. Modern encryption technology is fairly sophisticated. The cloud services are also well protected. So I think it's a reasonable concern, but probably not an overriding one, I would say. The other thing is, the way that we're using the devices is patients are opting in, right? So it's not being forced on anyone. We have a partnership with Anthem. We do startups as well. I'm not personally involved at the level that Milton is, but we do have startups, and we have a partnership with Anthem, which is the third largest medical insurer here in the U.S. And they're interested in deploying devices onto their customer base to capture data that will help them set insurance premiums. And it's all on an opt-in basis. So if you feel like you have a really healthy lifestyle and you want to engage with Anthem to quantify that, then you could save on your insurance. So it's a voluntary system in that sense. So we worry about data security. I don't think that is an insurmountable roadblock, though, to thinking about how these technologies can be deployed into our healthcare system.
Great. Thank you, John. Another question concerns whether we're asking too much of patients with a lot of the device innovation. Why is the assumption that more choice for patients who likely lack medical knowledge might be overwhelming, place a lot of stress on people if you ask them to do more to take care of their own health? Does one of you have an opinion on this? Do you want to jump in on this? Vivian, you're a medical practitioner in addition to working in this space. Give us your perspective.
Well, I really appreciate this question, Meryl, because specifically you were saying about the increased stress and cognitive load when people are pushed to take, quote, care of their own health care. And I think that's a very important point, because you're not worrying about people taking more care of their own health. It's the actual health care burden. I think people absolutely should be responsible for their own health. Obviously, their behaviors really drive their own health. But what's happening, we're seeing, for example, in the employer market, just really steady rise in these high deductible health plans where you really are, you're paying for the first several $1,000s of your care, and then you're being expected this idea that you're a consumer of healthcare, just same way in which you might buy a car or a pair of jeans. And so we give you enough information, you can go be a very informed shopper. I think there is some element of value to that, but it might be, I think we might be expecting too much. And certainly if you're having an acute issue, if you're having chest pain, you're probably not going to be sitting there asking the doctors for their quality ratings as you go in there for care. So I think that we've probably shifted too much of the responsibility. I write about this a little bit in my book, The Long Fix. Shifting all of that responsibility to employees what we've found with, for example, high deductible health plans is that, yes, in the first year, there is a reduction in overall cost of care for employees by about 20% on average, but that most people are indiscriminate about their reduction in use of healthcare. So that even with the Affordable Care Act, where preventive care is free, people will just stop getting that preventive care too. They'll just stop using everything because of the high deductibles that they have now. So I don't think it's a sustainable model. I agree with you that it adds stress, cognitive load for most people who just don't. There's a huge asymmetry of information. People don't really understand enough about healthcare to make good decisions, which is why it's incumbent on the people who are responsible for a lot of that payment, whether it's their employers or their insurers or health systems or the government, to try to drive the value, to try to hold the standards of quality and push down on the cost of care, because that's kind of where the levers are the strongest, not at the individual level.
Right. Thanks, Vivian. There's a question that's I think in your area, Milton, to do with entrepreneurship. That is, how should we encourage private markets for public health? particularly entrepreneurship in public health, some of the things that we've been talking about. Do we need explicit subsidies? Or already do you think enough incentives in place? Milton, what's your perspective on that?
We can always use more money as entrepreneurs. We would never turn that down. I'm not sure. Well, look, more money will, in a focused manner, will lead to, I think, will lead to greater innovation in that focused area. Just, I think, is the whole thesis of the NIH and NSF and DARPA and these types of agencies that fund. So I think we know that if more money is steered in a certain direction, that you will get more on the other side of it. Do we need it? I think if we bring this back, Vijay, to the pandemic, I think we did an awful lot out of necessity because of the pandemic. We did push Operation Warp Speed. We can, in a depoliticized way, we got to innovation or to a particular set of drugs a lot faster than we would have otherwise. And that was backed by, that was fueled by a pandemic as well as by funding, right? And so we know that we can be more productive out of necessity, but also out of resourcing. But I listen, I think it doesn't have to require a ton of additional pools of money. I think there's a lot of money out there. You do need to know where to look for it. And if you are on any of these innovation curves, like surviving in an environment of a pandemic and living in a bubble environment, and your technology is going to, in some way, shape, or form, help us persevere through a pandemic, there is money out there for you to innovate around. You just got to kind of know where it is.
There's another half of this question that really is more directed to John, and that is, Milton talked about the money piece of this. There's money, it sounds like, and clearly NIH has a long record of funding things that went on to spur medical innovations, including in devices. But John, the question is really about what's the role of, let's say, academia in helping with testing or acting as an accelerant or as a partner in collaborations with the entrepreneurial sector. How do you think about this, particularly when you talk about areas where there isn't an immediate commercial viability, let's say, but there's a clear innovation opportunity? How do you go about it?
Yeah, I mean, I think university labs are an important part of our innovation ecosystem here in the U.S. Most universities, as you probably know, and others probably on the call as well, most universities have licensing offices in place. They front the cost of filing patent applications around new ideas coming out of academic labs. Those patents can become available to licensees. Many times it's startups launched by the inventors and the academic PIs, and we're certainly very active, in that space in a sense. And so, I think a lot of the sort of fundamentally new ideas are emerging, from university labs. I mean, that's just sort of my personal perspective on it, based on where I'm sitting. But I think you could kind of look at the list and make a pretty solid argument. I think startups are good at translating those new ideas into commercial products, and then eventually large company partnerships allow for scale. So that's kind of the way that I would see the progression, and the way that I've lived it, in terms of the startups that we've done over the years. I would also sort of add to Milton's comments. I think there's probably not a lack of funding available for med tech startups and innovation at this level. Certainly, within the university environment, we've benefited tremendously from NIH and DARPA and NSF and DOE and all the usual suspects. But if you're doing, med tech development, there's tremendous resources available through foundations. So we are funded, the startups that we have are funded at a very high level by Bill and Melinda Gates Foundation, Save the Children Foundation, the Gerber Foundation, Friends of Prentice Foundation, the Ryan Family Foundation. There's all kinds of non-governmental organizations, I guess, that can kind of bridge development costs. And I think you can even do these things, and this is the path that we're taking, without VC investors. I think you can take it all the way. We'll see how far that can go, but I think these kind of non-traditional sources of funding for us are becoming more important over time.
Great. So it really sounds like that neither regulation nor lack of resources is the impediment. So that's a bit of at least a yellow light, if not a green light, for more innovation. We just have a couple of minutes before I turn it back to Hayes. Very briefly, we have a couple of questions that relate to artificial intelligence and the analytics piece of this. Vivian, did you want to give a quick word on the role that you think AI can play in dealing with this data deluge? Obviously, your parent company is one of the world leaders in thinking about how to use AI. How are you applying it when it comes to the flood of data that many doctors say, I don't know what to do with all this data? How are you going to help them?
Yeah, so that's really a key question. I think that we want to differentiate data from information that's actionable. And whether that's whether that's information that's actionable for the physician or actionable for the patient, or ideally both, and that whole idea of co-producing health, I think that's really got to be the focus. I certainly know that when we started with the continuous glucose monitor, no physician wanted 24/7 tracings of every single one of their every single one of their patients with diabetes to come in every morning. And so how can we use analytic tools with or without AI? You know, right now AI is, of course, incredibly powerful, but just generally speaking, how do we use our analytic tools to distill all of this information into what is meaningful for that patient? And that's where I think it's been very important to connect not only the data scientists, but also our user experience researchers and user experience design people who really understand behavior change, who really understand human psychology. Because you alluded to this earlier, Vijay, that this is really, a lot of this is about behavior change and providing the right amount of information for people to make the right decisions, whether they're the doctor, the nurse, or the patient. And so to the degree that we can use AI as a tool that can guide that, I think we can be really empowered. There are two examples. One is the example of the images and the data coming in so that we can make recommendations about meals, for example. Another is all of the information that we might have from claims data or EHR data or these sensors that can also identify or who is at greater risk of a particular condition or a deterioration, so that we can focus our resources on that individual. Both of those are really important use cases, I think, for AI today.
Well, you mentioned giving the right amount of data. I think this panel has given us the right amount of data to get us excited about the future, while at the same time showing us the complexity of the field of healthcare. I leave both troubled by the challenges ahead, but more so encouraged that we have some of the sharpest brains out there working on this and coming up with inventions that have been accelerated by the pandemic. So I hope you'll all share with me my gratitude to the panelists, but also my enthusiasm for the health innovation future as I hand it over to Hayes.
And I join Vijay in expressing enormous gratitude to the panelists. This is really quite an inspiring conversation. And of course, thanks to Vijay for facilitating the lively discussion. Thanks to all of you for joining us on this Friday afternoon, wherever you are. We appreciate you coming here. Also, a big thanks to Dean Julio Otino, who of course brought us all together and makes events like this possible. We want to be sure that you are aware of other events coming your way. There will be others like this in the coming months. So to keep up with Farley doings, please check farley.northwestern.edu. You can also find us on social media. Thank you, everybody, very, very much, and have a great weekend.
Thanks, everyone. Bye-bye.
Thank you.